Hi, everyone. I'm Randy Burd. I'm the chief of the Division of Trauma and Burn Surgery at Children's National Medical Center. And I would like to talk today about ED thoracotomy, in particular, how to manage kids who come in with CPR after injury. And so when the kids come in CPR after injury, I think that there's several reasons that you need to open up the chest and do an ED thoracotomy. One is to repair an injury, so immediately repair a cardiac or pulmonary injury. The second is the cross clamp of the descending aorta. By doing this, you can increase perfusion to the central blood vessels in the brain and the coronaries. You can release cardiac tamponade. You can do open cardiac massage in the rare circumstance where the patient has air embolism as a cause of arrest. You can evacuate air embolism. I think there's three questions. So when a kid comes into the emergency department and undergoing CPR, there's three questions you should ask to try to figure out what to do. The first is, was the child injured by a blunt or penetrating mechanism? The second question you should ask is, how long has CPR been going on? And for some EMS or hospital or pre-hospital providers, we can trust the information. It's accurate. They can tell you it's 3 minutes. You can believe it's 3 minutes. Other times they say 10 minutes, you're not sure if it's 10 minutes or 15 minutes, but make an honest assessment of what the duration of CPR is before the patient arrives. The third question is there any signs of life? Does the patient have any signs of life? And if you answer these three questions, then you have a good idea of what to do for that patient. So here's why those questions kind of interact together to come up with a recommendation of what to do. So if the patient comes in with a penetrating injury, in particular penetrating injury to the thorax, and that patient has signs of life, and then the surgeon should be opening that patient's chest. They should open that chest so that they can get in and identify and manage injuries that can save the patient. On the very bottom here, if the patient comes in and they have injured by a blunt mechanism and they arrive with no signs of life, then you shouldn't do an ED thoracotomy. These are guidelines based on the Eastern Association of Surgery of Trauma best practice guidelines publication. You can see in between, depending on where the location of the injury and type of injury and whether it's signs of life, then ED thoracotomy may or may not be indicated. So let me provide a little more specificity here and make this a little more useful to do. So what are signs of life? So these are the 6 elements that define signs of life. Pupillar response, the patient's breathing, you can feel a pulse, you can measure a blood pressure, the extremities are moving, or there's cardioelectric activity. And you know that if some patients come in and they have no blood pressure, then some of these things will also be present. So for example, if you have no blood pressure, you also have you may have no palpable cardiac pulse at the same time. These things sort of overlap. To make a comment about cardiac electrical activity, really this is talking about PEA. It's not talking about wide complex rhythms. It's just talking about PEA. So these are the signs of life. So when a patient comes in with full arrest, you ask the question, blunt or penetrating injury? Do they have signs of life? And how long was the CPR going on? And so here's why the blunt and penetrating mechanism and duration matter. Some trauma surgeons believe that if the patient is undergoing CPR, arrives undergoing CPR after a blunt mechanism, that unless they arrest, if that arrest doesn't occur right in front of your face, then that patient has a non-survivable arrest. That patient won't have, unlikely to survive, and if they do survive, will not have a meaningful neurological outcome. So some say it's 10 minutes for blunt, others won't do an ED thoracotomy or continue resuscitation efforts if the patient doesn't arrest in front of the team in the emergency department. Penetrating injury, you have a little longer time. Some say 10 minutes, some say 15 minutes, but there's a little bit more leeway. And the reason is that these patients generally have something you can fix. When you open up the chest, you can fix something. Let me just make a brief comment about needling the chest. This is a common thing that you see that when you have a patient that's an extremis, you're trying to figure out what possibly you can do. And I think that if you're serious about decompressing the chest for a tension pneumothorax, you really should be putting in a chest tube or doing finger thoracotomy, basically doing everything short of putting the tube in. So making a hole in the chest, letting the air go. Needling the chest rarely relieves tension pneumothorax in a significant way. And I think that this maneuver is probably something that you should do only as a stepping stone to putting in a chest tube. And I think that one category that this may be a good maneuver is patients who come in one traumatic arrest who have signs of life as a temporizing maneuver as you move towards doing something to save the patient's life. So let me just talk about, so I know most of the people who are going to be listening to this are not going to be doing ED thoracotomy, but I think it's important to understand what the steps of the procedure are and what the goal and what the surgeon is thinking about during the procedure. So I'm just going to play this brief video starting at minute 122.
First can be left anterior, so that be performed.
Okay.
Technique. A left anterior lateral thoracotomy incision is employed. The incision begins at the sternal border at the level of the fifth intercostal space, which correlates to the inferior border of the pectoralis major muscle, which is just below the nipple. In women, the breast should be retracted superiorly, and the incision can often be made in the inframammary fold. The incision is carried transversely across the chest beneath the nipple, and then curved gently toward the axilla, but completely extending posteriorly as far as the patient's position allows. The skin, subcutaneous fat, and chest wall musculature are incised with a knife to expose the ribs and intercostal space. The intercostal muscles and the parietal pleura are often opened with a curved nail scissors or as sharply with a knife. As always, the incision should be just above the rib to avoid the intercostal neurovascular bundle. The incision is opened with the assistance of a Finicchietto retractor, always placed with the hand facing towards the bed to allow extension of the incision across the sternum if necessary. Advantages of this approach include rapid access with civil instruments, able to be performed in the supine position, the ability to extend across the chest for better exposure. The next step should be to rule out and to relieve a pericardial tamponade by performing a pericardiotomy. The pericardium is incised widely, starting at the apex of the heart and extending superiorly. Care must be taken to identify and preserve the phrenic nerve, so the pericardiotomy incision should be performed anterior to and parallel with the nerve. The loose pericardium can be grasped with the forceps and incised with the scissors, but if tense in the presence of a tamponade, it may be difficult to grasp and necessary to gently begin the incision directly with the scissors or scalpel. Once the pericardium is open, the heart should be delivered into the left chest by placing a hand into the pericardium and behind the heart to bring it out of the pericardium and into the left chest. In conjunction with relieving a cardiac tamponade, clamping the thoracic aorta provides two additional benefits. First, it allows redistribution of any cardiac blood flow to the coronary arteries and the brain. Second, if there is associated intra-abdominal hemorrhage, this will be diminished. The technique of cross-clamping the thoracic aorta begins with evacuation of blood across the left chest and elevation of the lung. It is rarely necessary to release the inferior pulmonary ligament, although this does improve exposure. Often, exposure and clamping of the thoracic aorta is done without direct visualization, so tactile feedback is critical. As the surgeon's hand is placed into the left chest, the spine can easily be palpated posteriorly. Lying just over the spine is the aorta, but it is covered by the parietal pleura on the left. The pleura must be dissected free with either the surgeon's fingers or the tip of a clamp. The pleura is often easy to dissect in the older patient, but can be very strong and difficult to release in the younger patients. Once the aorta is dissected free so that the surgeon's fingers can be placed above and below it, an aortic cross-clamp is placed. The esophagus is also closely associated with the aorta at this level and should be avoided. Placement of a nasogastric tube helps tactile identification of the esophagus to avoid injury caused by inadvertently clamping it along the aorta. Once the pericardiotomy and cross-clamp have been completed, any identified injuries must be addressed. The most common injury amenable to repair are to the heart and the lung. Since the patient is not yet in the operating room, temporary measures to control bleeding are preferred so that the patient can be moved to the operating room for definitive repair. These may include digital pressure and control of cardiac or great vessel injuries, simple suture, clamping or stapling of any cardiac injuries. Care must be taken to avoid suturing across any coronary vessels, so vertical mattress sutures can be used to avoid them. Balloon tamponade of large cardiac defects can be attempted, but extreme care must be used to avoid excessive traction, which can worsen the injury. Stapling or suturing pulmonary injuries can be rapidly achieved. If air embolism is suspected, aspiration of the ventricles can be performed with the patient in the Trendelenburg position. Pillar cross clamping of major pulmonary injuries can control bleeding and may also prevent air embolus, but will almost always lead to a pneumonectomy and should not be undertaken lightly. Of course, if no source of hemorrhage is found in the left chest, consideration must be given to extending the incision across the sternum and into the right chest, as well as considering the possibility of an intra-abdominal injury and the need for a laparotomy. While looking for other sources of hemorrhage, the left thoracotomy provides excellent exposure for open cardiac massage done by pressing the heart between the fully extended palms and fingers. Of course, any manipulation of the heart can lead to arrhythmias, which must be recognized and treated promptly. In particular, lifting the heart to control a posterior cardiac injury will often result in arrhythmia. Internal paddles should be immediately available for defibrillation on a low setting of 10 to 50 joules. Once the patient has regained a sustained, spontaneous circulation, they should be transported to the operating room for continued resuscitation and definitive repair of all injuries.
I'll stop right there. And what you just saw, this entire process that you saw, is, well, here's my age-restricted video, but this is a process that goes on. It has to happen fast. It has to happen quickly, and you have to have control of the aorta, exposure of the heart, decompression of the pericardium literally within minutes. And I'm going to show you a video that will show what it looks like in the real world. Let's see. Hey, can you still see my video, or is it not YouTube?
We're on the age-restricted screen.
Okay, let me unshare and then I'll share again. Bear with me. I'll stop sharing and then I'll share again. This is my old video. 1 second. Okay, can you see open thoracotomy, viewer discretion advised?
Yes.
Okay, this is more what it looks like, and to give you a sense of all those steps that you just saw have to be done within minutes. And here's the real world.
That's the wrong way. Go ahead. You got the big can? You got the big plant? Take it on across. You're gonna have to go right on across up there. Open that chest up more. Open up the chest more up there. Take it on.
And I'll stop it right there because it gives you a sense of the chaos and time urgency of proceeding with ED thoracotomy. And while it's important that everybody in the room be supportive of the team while they're proceeding with this procedure. Let me go back to my slides here. Second one, I'll share again. And you can see, Cindy, why you need to know about this. Can you see why you need to know about this, Cindy?
Yes.
Okay, so why do you need to know about the reasons to proceed with ED thoracotomy and some of these criteria for when you would stop resuscitation in a patient with a blunt traumatic arrest? I think it's important that we all have a mutual understanding of when it's appropriate to stop and when futility has been reached. I think it's also important to know when to intervene, when we need to move forward, and that all of us as a team support the actions that make a difference. So if a patient comes in with a blunt traumatic arrest and they do need an ED thoracotomy, then that should be the focus of what the team is doing, because all other maneuvers are not going to make nearly the same difference as identifying and managing an injury that you can treat. And then sort of a corollary of that is avoid actions that don't make a difference. So putting a needle in, if a patient comes in with a blunt traumatic arrest or a penetrating injury with arrest, if ED thoracotomy is needed, doing things like putting chest tubes in and putting needles in the chest, those are things that aren't going to make any difference whatsoever. And so doing them as preliminary steps instead of proceeding directly to ED thoracotomy and supporting the surgeons in doing that procedure is not what we should be doing as a team. And so let me just finish up with some questions that will probably provoke some comments from my colleagues here. So I'm going to stop the share and do another share. And there's a series of questions that we don't have a good interactive way to do it, but I'm going to ask the question, give a pause so you can think about how you would answer these questions. And you can see my questions, Cindy?
Yes, I can see them.
Okay. So a child arrives in full arrest after an injury. Which of these activities should take precedence to increase the chance of survival? High quality chest compressions, immediate treatment of hypovolemia, cardiac tamponade, or tension pneumothorax, securing a stable airway, cardioversion to a normal cardiac rhythm, or administration of appropriately dosed epinephrine. This is a child comes in full arrest after an injury. I'm deliberately not telling you whether it's blunt or penetrating or at the time. So the Resuscitative Council of European Resuscitation Council has answered this question, given recommendations here, and the answer is B, immediate treatment of hypovolemia, cardiac tamponade, or tension pneumothorax. So identifying treatable causes of the arrest and managing those should be the priority of the team. All these other maneuvers can be done concomitantly and certainly have a contribution, but it's getting to the core reason and managing the core reason that the patient is in arrest is a recommendation of how you should proceed. And actually, this A is probably an answer that many of you chose: high quality chest compressions. And high quality chest compressions does absolutely no good if the heart is empty and there's a hole in it. And that's why the focus should be on identifying and treating the cause of the arrest. Second question, which of the following is not a criterion for signs of life? PEA, a GCS of 3, no spontaneous respiration, no extremity activity, or non-reactive pupils. Which one is not? It's a kind of a double negative, but which one is not a criteria for no signs of life? Which one would be a criteria for signs of life? And the answer, of course, is PEA. So if you have electrical activity of the heart, that's a sign of life, and that should be a contributor to your decision about whether to continue with resuscitation and in the right context, whether to proceed with an ED thoracotomy.
Dr. Burd, a question on that. What about Vfib or other types of fibrillation that you might have either before or after PEA?
Yeah, so it's controversial. If you have Vfib rather than PEA, the chance of you being resuscitated is pretty low. I think some people will, in fact, try to convert Vfib over. So I think that's where it's a little gray zone. I would say, though, that if it's a wide complex rhythm, that's probably is not something that should be resuscitated. So VFib is sort of in between. And I think it's reasonable if you have other favorable factors, for example, say penetrating chest injury, those favorable factors would suggest that it's reasonable to proceed. A child presents after a major blunt injury, has received 20 minutes of CPR and arrives with no signs of life. Continuing CPR in this patient is justified if the parents will be arriving soon. Helps the medical team better manage a stressful situation. Helps build consensus that all interventions have been attempted. Is paternalistic and deceptive. Supports the education and training of the team. So the answer here, and probably to many of your surprise, is D, is paternalistic and deceptive. The concept that you should wait until parents arrive before terminating resuscitation, there really is no medical or ethical support for that approach. The concept that continuing fetal resuscitation helps teams better manage a stressful situation is also not something that's ever been proven. In fact, some would argue that continued resuscitative efforts in a fetal situation provides additional time of stress for the team. Builds consensus that all possible interventions have been attempted. I think that in this context, in this patient context, that this patient has a non-survivable injury and resuscitation should be stopped. And I think that there really is no other interventions that can be attempted that will make a difference for this patient. And so building consensus should instead not be around trying new interventions, but instead establishing the information that supports stopping the resuscitation. That is, that the patient had a blunt injury, that the resuscitation time is really 20 minutes, and the patient in fact does have no signs of life. And then supports the education and training the team. Again, I go back to this resuscitation council recommendation. They argue that fetal resuscitation actually does the opposite. It doesn't teach teams how to appropriately manage patients. It basically it steers them away from making the right decision in a fetal situation. Next question is: a child arrives after undergoing CPR for 15 minutes after being involved in a motor vehicle crash. The child has no signs of life. The next best step for this child is A, declare the child dead from a non-survivable injury. B, perform bilateral needle chest decompression. Intubate the patient, give 2 rounds of epinephrine, and finally the option of giving uncross-matched blood and activating the massive blood transfusion protocol. So I hope by now that you know that this child meets the criteria of having a non-survivable injury, and that the child should be declared dead from a non-survivable injury. And the focus of the team's effort should be establishing the time of the CPR, the mechanism of injury, and the presence or absence of signs of life. These additional maneuvers are futile and will not have any benefit for the patient.
Dr. Burd, just another comment. I think what we see quite a bit in real practice is patients do come in with CPR greater than 15 minutes, and the teams do a lot of times you'll hear that, let's give 2 rounds of epi, let's see if they respond. So if I have a child who comes in 20 minutes down with that 2 rounds of epi that we're going to try, even if they could get a heart rate back, what is the I guess the statistic on survival of this patient?
Yeah, if you come in that context, that child has no chance of meaning neuro. First of all, survival is very, very low, and in the rare circumstance where the patient return of spontaneous circulation can occur, that patient will be neurologically devastated. So those two things are certain in this context. I'm sorry, did I answer your question?
You did.
Okay. In the presence of hemorrhagic shock, mechanical ventilation can A, increase thoracic pressure, B, increase diastolic filling in the presence of cardiac tamponade, C, improve oxygenation in the presence of a tension pneumothorax, or D, decrease blood loss from venous bleeding sites. And the answer here is A, which is increased interthoracic pressure. And it's important to know what the consequences of increasing interthoracic pressure. It can decrease diastolic filling when there's tamponade. It can worsen oxygenation in the context of a tension pneumothorax, and actually can increase blood loss from venous bleeding sites. So B, C, and D, the opposite occurs with increased intrathoracic pressure associated with mechanical ventilation.
So with the patient in hemorrhagic shock, then, as the team gets ready to intubate, we should be looking for tension pneumothorax and be ready to intervene, as well as, if they're truly in hemorrhagic shock, think that we're going to need more fluid, more blood product volume, and have that ready.
Yeah, so if a patient comes in hemorrhagic shock and you're about to intubate the patient, you need to be thinking about concomitantly giving that patient blood. If you have knowledge that the patient's in shock, and particularly if they're in hemorrhagic shock, giving that patient blood will avoid the negative consequences of positive pressure ventilation on that patient. So that should be a concomitant priority for that particular scenario. A teenager sustains a gunshot wound to the chest 2 minutes before arrival. CPR is initiated. The patient has no signs of life. The next best step is EFAST, and EFAST is where you ultrasound not only the abdomen but the chest, looking for pneumothorax. ED Thoracotomy, opening the chest, looking for injuries and manage them. Intubating the patient, putting a large bore catheter in the groin, a thermal portus placement, or transfusing blood. So this question is a little bit nuanced, and so if you believe that the patient needs to arrest in front of you in order to proceed, then the patient in fact has no signs of life, then then proceeding with anything else is futile. But let's say that you accept a wider window of time, 2 minutes before arrival, then this patient should probably have an ED thoracotomy. Now, it's very hard to do an ED thoracotomy in a patient who's not intubated. So you almost want to be doing these two steps at the same time. And of course, you want to do some of these other maneuvers as adjuncts to it. But the thing that's going to most help this patient, if this is within your personal window of resuscitation, or ED thoracotomy window, then all efforts should be focused on doing the ED thoracotomy.
Dr. Burd, can you just briefly speak about fast exams in the pediatric population? We're often told that, they're not sensitive specific, but can you speak about their unique role in this situation? Yeah,
so I think that fast has been shown in more than one study to be not sensitive or specific for identifying intra-abdominal injury. And to get to Liz's question is that in a patient that's in extremis, the FAST can provide additional information to help decide what the next best step in management is. So if the patient is not in full arrest but is in shock, it can help determine whether there's blood in the abdomen. It can help determine if there's blood in the pericardial space. It can help determine if there's a pneumothorax or blood in the chest. So it can provide very useful information that you would otherwise have to get a CT scan or do a chest X-ray or get do some other more time-consuming evaluations that may in fact require you to leave the trauma bay. The other thing that the EFAST can help with is to look and see if there's cardiac activity. So if the patient comes in full arrest, they're undergoing CPR, doing an ultrasound of the chest and seeing if the heart is in fact beating can give you a clue that the patient does have one of the 6 signs of life. And that would give you useful information about making a decision for that patient. And let me just finish the last few minutes with the final question. Is compared to resuscitative thoracotomy, in adults. So compared to opening the chest of an injured adult patient in the emergency department, this procedure for children has different reasons for doing it, different indications. Should be stopped using, should be terminated using different criteria. Is successful or not depending on the type of injury, whether it's injury is blunt or penetrating. Has a better survival in kids than adults. It also is also related to patient age. And the answer here is also dependent on patient age. So let me just go through some of these other answers and tell you why these other answers are not. So there is no evidence that kids do better with ED thoracotomy than adults. In fact, the criteria and the criteria for doing it and the criteria for terminating all resuscitative efforts are essentially the same. And that includes what type of injury the patient has as part of that decision-making process. E is a little bit of a nuanced answer. If you're an elderly patient, an elderly adult versus a younger adult, your outcome from ED thoracotomy is going to be worse. No big surprise there, regardless of the reason that you undergo ED thoracotomy. In kids, there also is an age relationship. Younger kids do worse than teenagers. And the reason that younger kids do worse than teenagers is that ED thoracotomy in younger kids is usually in the context of blunt injury, whereas teenagers more commonly undergo this procedure for penetrating injury. And patients who undergo ED thoracotomy for penetrating injury have better outcomes. So teenagers do better, but mostly because they have usually a different profile of injury. And I think that's the end of the 30 minutes, and open for questions from my esteemed panel here before we finish up.
I had a question about how important is the, it was said in the video, the nasogastric tube. I know that in our code room, we only put in OG tubes, and I was wondering how important that is to you as the surgeon performing this.
Yeah, I think it really does help. When you're reaching in the chest and trying to find the aorta and distinguishing it from the esophagus, having a tube in the esophagus, because having a tube in the esophagus really helps. You have to remember is the aorta is easy to find when it's beating and filled with blood, but in this context, it's empty. And so all the anatomic clues you can get will be helpful. So nasogastric tube or orogastric tube, whatever is appropriate in the context, is very, very useful.
Okay, and you would never want to wait to do the thoracotomy for the OG tube, but if they can do it like simultaneously, that would be helpful, correct?
Absolutely, and it gets back to my point is that don't be distracted with maneuvers that keeps the surgeon moving forward. If the patient meets the criteria, we want to do everything to keep that process moving forward. And I think it's an easy thing to do concomitantly.
What would you say would be your one request of the nursing staff in the code room if you're the surgeon placing the if you're doing the thoracotomy? What would your one request to nursing be? Yeah,
is that the focus be on facilitating the procedure, because that's really what's going to make a difference for that patient. So by facilitating that procedure is if you don't have a role in the room, get out of the room. If you can make space available to get into the chest, make that space available. If you're performing an ancillary procedure in support of the ED thoracotomy, nasogastric tube placement, intubation, etc., is that you need to understand is that moving forward to getting into the chest will do more for the patient than those ancillary maneuvers being performed quickly. So you got to kind of reprioritize. We focus on those individual tasks, but you just have to remember is that the ED thoracotomy that's successful is what's going to save the patient.
If you do an ED thoracotomy and you do get electrical activity back, patient obviously is not stable, I assume the next destination for this patient will be the OR?
Yes, absolutely.
And so just a statement to those is that there is an emergency OR packet down by the code room in order for us to make sure that the operating room can be ready for a patient that's emergent.
Yeah, and this comes up if you're in emergency department somewhere and you don't have the ability to push that patient forward into the operating room, you have no surgeons in your hospital, you don't have no OR availability, then the recommendation is that you not in fact perform ED thoracotomy, because you're not going to have you're going to have no forward destination to treat that patient. The likelihood of survival of a patient, even successfully resuscitated with clamps in their chest and an open chest to another hospital, the likelihood of survival with such a transport, it's very, very unlikely.
So Dr. Burd, after you do an ED thoracotomy, my assumption is these kids need to, their next place that they're going to go is the operating room. And so more of a statement than a question is that people need to know how to quickly get kids to the operating room. And here at main campus, we do have a just-in-time tool that the NAL has in order to have that conversation with the OR so they can be prepped and ready for this type of emergent patient.
Yeah, absolutely. So what happens is you do ED thoracotomy, you bring the patient back, you get back, you fix the heart, you cross canal the aorta, and you get back blood pressure, whatever you do, fix the lung. You now have a patient in the emergency department who had a semi-sterile operation and their chest is open. So that patient needs to go to the operating room to have their chest closed, have injuries more formally addressed. And that really needs to be, you can't do that in the emergency department. And I think as a corollary of all that is that if you're in a setting where you don't have an operating room that's available and surgeons to perform the next step, doing ED thoracotomy is probably not a good idea. In fact, I don't think you really should be doing it. This has come up in different contexts, even in the district. If you don't have a direction for that patient to go, you shouldn't be doing it. Well, great. Well, thanks, Cindy, for inviting me to do this, and I hope this was useful to those of you who watched this presentation. And thanks to my esteemed panel for great questions.
Thank you so much.